later. In continuation of that, today we will present the second and last part of the English class, inshallah. Our today topic is homeopathic approach to the management of surgical disease condition. Last part. If anyone has any question to the topic, you will have the opportunity to present your questions at the end of the program. Another request to all to maintain class order and beautiful environment. Please keep your mic and camera off. Thank you, everyone. Now I invite today's speaker, Dr. Sheikh Faruque Elahee, Honorable President of Bangladesh Homeopathic Parishad, to present his discussion on the assigned topic. Thank you, sir. Please continue your discussion.
Yes.
Thank you.
Yes. Thank you. Dear viewers, Assalamu alaikum. Good evening. Adab. Let me start today my discussion from urinary system. I'm having some problem. Dr. Patwari,
Yes, sir.
I'm having some problem.
Your screen is not showing, sir.
Stop presenting. Okay, let's see. I think it's all right now, is it? Hello? Hello?
Yes, sir.
Okay. Let us start our topics. I would like to start from the urinary system so that if anybody was absent in the last class, he may have some benefit. And also, I have added some new topics in the urinary system. So who were present in the last class, they will get this new topic as well. So you see, in the urinary system, let us see the anatomy of urinary system, because I feel most or at least few of our viewers may not be very much conversant with the finer anatomy of the urinary system. But I am not going to tell you the finer anatomy, only the gross one, for the ease of our discussion. You see, this is the urinary system. You can see there are two kidneys and there are two ureters. These are ureters who carries urine formed by the kidney to the urinary bladder to store here. Then this is the urinary bladder. Then from the urinary bladder there is urethra, which will take the urine to outside. Now you can see on the right hand side of picture there are two kidneys, and you can see this is the abdominal and aorta, and this is the inferior vena cava.
Can you hear me?
Aorta. Hello.
Sir, we can see your presentation. Sir,
Any problem?
we can see your presentation, sir.
There is no presentation, sir.
Let me start from the beginning then.
Yeah,
Let me
yeah.
see. Yeah. Let me see. Hello. Sorry.
Yes, sir.
Do you hear me now? Hello, Dr. Noor.
Yes, sir. Yes, sir. Now your presentation is
Do you see my
Okay,
presentation?
okay, okay. Yes, sir.
yeah.
India as you wrote it, showing in your image and presentation. Thank you, sir.
Oh, okay. So you have blood from heart to the kidney to be filtered the kidney and making urine. This one is coming through this ureter, one ureter from each side. Bladder it goes outside through urethra. This is something else. There is another picture you can see. You can see a relation of the organs in relation to anatomy of the bladder. It stays in the pelvis, and these two kidney are beside the lumbar vertebra on the back. And you can see this is the urinary bladder, and this is female urinary bladder. This is male urinary bladder, and I believe you can see there is some difference. It is almost same, but we see you find this urethra, which is in case of female, and in case of male, you can see here it is a very long one. You see that 1.5 inch. The length of the urethra is only 1.5 inch from the urinary blood flow side. And in case of male, it is 10 to 8 inches, you see, 6 times longer. From here up to here, this is the male urethra. So there is one problem. What is the problem? You can understand. You see, the female urethra remains with the colibacteria. This is called colibacteria. They because uh, this is a failure.
Mr. Moderator, we are not
All you got
getting to it.
7 to 8 inch.
Sir, can you hear me, sir?
This is the prostate.
Our words are not clear due to your
So this
internet
value
problem.
has three parts.
Sir, can you hear me? Hello, sir.
This is called prostatic urethra. Which one?
Excuse me, sir, we are not hearing clearly.
Hello, sir. Can
So
you hear
yes.
me? Hello, sir. Your words are not clear due to your internet
Hello.
problem. Sir, we are not hearing clearly, sir.
তাই আহ, ওদের ঢুকছি। আমি মোবাইল দেখ মোবাইল আমি মোবাইলে
স্যার, আপনার মোবাইল নেট খুবই স্লো, যে কারণে আপনার কথা আমরা শুনতে পাচ্ছি না।
হ্যালো
Yes, sir.
শুনতে পাচ্ছেন আমার
We are hearing clearly. Yes, sir.
হ্যালো আচ্ছা
Sir, we are
তাহলে আমি
hearing now.
আমি আপনারা এই যে আমার প্রেজেন্টেশনটা পাওয়ার পাওয়ার পয়েন্টটা শুনতে পাচ্ছেন না কিন্তু আমি আমি চাইলে মোবাইলে আমি কথা বলি পাওয়ার পয়েন্টটা শুনতে পাচ্ছেন না কিন্তু আমি আমার আমার মোবাইল কানেকশনটা চলে গেছে Hello.
Yes, sir.
তাহলে এবার শোনা যায়?
শুনতে পাচ্ছেন আমাকে?
Yes, sir.
হ্যালো।
Yes, sir.
আচ্ছা শুনেন, আমার যেটা হয়েছে, আমার এখানে কারেন্ট চলে গেছে। আমার আমার যে ব্রডব্যান্ডটা চলে গেছে। আমি কথা বলি, আমি মুখেই কথা বলি আমার এই মোবাইল সেট দিয়ে। আবার
Okay, okay.
কারেন্টটা যখন আসবে, আমার মনে হয় আসছে, আবার আসছে আমার মনে হচ্ছে, তাইলে আমি আবার মিট করব। একটু রাখেন, আমি দেখছি আসছে মনে হচ্ছে। আচ্ছা, আমরা আসছে 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 দিচ্ছি আমি। আমাকে ল্যাপটপ, ওকে, ফাইন ফাইন। So you see, there is prostate. So the male urethra has three parts. This is prostatic urethra, this one. This is called membranous urethra, and this is penile urethra. This is penile urethra. Now, let us keep in mind this picture, then we can discuss the urinary system diseases. We already discussed urinary calculi, so let me skip this discussion because I already did discuss last week. Also, the congenital deformity, let me skip. Let me go to Peyronie's disease, which was not discussed last week. This is the new topic, Peyronie's disease. Why I put this disease here? Because I find there are so many cases nowadays coming with Peyronie's disease. And I believe even many young MBBS doctors, they may not know this Peyronie's disease, though it is mentioned and written in surgery book. And nowadays, I find this is not uncommon. So let us see what is Peyronie's disease. Peyronie is the name of a surgeon. According to his name, this is called Peyronie's disease. This one is new today. That's why I am going to discuss this Peyronie's disease. This is the Peyronie's disease. You see, in penis, penis is composed of three structures. Three structures. Let me show you here. Let me show you here. You see, this is penis. You can find the base of the penis. Penis has three cylinder-like structure. On the side, this is called corpora cavernosa, and in the middle there is corpora spongiosa. This corpora spongiosa contains the urethra, and this corpora cavernosa, this helps to erect the penis. Now, in the corpora cavernosa, there are nodules. You find some patients will complain that hello. So they will complain that there are some nodules in the penis, and penis become curved like this. You see, the penis becomes curved like this here because in the penis there is a nodule formed in this penile part, this corpora cavernosa, this muscular part, and this nodule curves the penis like this. The penis becomes curved. So this is a problem for the patient.
No, sir, I cannot see. I can see your picture, sir.
Other people, you can see. Hello, Dr. Anwar. Dr.
No, sir.
Anwar, you can see it. You can see.
No, sir. No, sir.
দেখা যাচ্ছে না, প্রেজেন্টেশন দেখা যায় না।
What can
We
I
are
do?
not watching you.
But my internet is working. I don't know. Welcome again. Okay. এটা বন্ধ করতে হবে তোমাকে। এটা দাঁড়াও দাঁড়াও একটু। না এটা বন্ধ করবো এটা এই যে off।
আপনি এখন একটা আইডিতে আছেন, যে কারণে প্রেজেন্টেশন আসছে না।
হ্যালো, আবার এখানে আওয়াজ করে তো। হ্যাঁ এটা আওয়াজ করে তো। হ্যাঁ এটা লিখলাম আবার আসবে কিভাবে? রিজয়েন। আচ্ছা হ্যালো
স্যার।
হ্যালো, হ্যাঁ শুনতে পাচ্ছেন?
জি স্যার, শুনতে পাচ্ছি।
তাইলে তো একটা অসুবিধা হবে, যেটা আমি আমার পাওয়ার পয়েন্টটা দেখা যাবে না, আমি কথা বলতে পারবো। এটা করবো
স্যার এইটা
কারেন্ট। হ্যাঁ
পাওয়ার পয়েন্টের দেখার দরকার স্যার।
এটার কারণে আমরা বুঝতে পারছি না।
how can I show the power point? I don't know, because I find my internet is working, but why you are not seeing, I don't understand. Okay, I come again. Just wait. Return to home screen. Design. Oh, I understand the problem, I think.
এবার অপশন আসছে, ওই করছে, কারণ ওইটা মিউট করে দিতে হবে স্যার। একটা ল্যাপটপেরটা পাওয়ার পয়েন্টের ওইটা মিউট করে দিতে হবে, শুধুমাত্র প্রেজেন্টেশন দিতে হবে, তাহলে আর ইকো হবে না। হ্যাঁ ইকো বন্ধ হয়ে গেছে। ও আপনি যেটা কথা বলবেন ওইটা তো আনমিউট করবেন। আপনার এটাও তো মিউট হয়ে গেছে স্যার।
স্যার মোবাইলেরটা আনমিউট করে নেন স্যার, ওখান থেকে আমরা অডিওটা পাবো। আর ল্যাপটপেরটা থেকে
ল্যাপটপেরটা দিয়েছে আমি ল্যাপটপেরটা।
আচ্ছা স্যার, এখন শেয়ার করে দেন। না না হচ্ছে না স্যার।
এখন হবে কেন? ওটা তো মিউট আছে।
আরে sorry I prepared so well. Anyway, let us start. Let us start again. Share. So can you see?
Yes sir.
Okay. So this is called Peyronie's disease. The penis is curved, but it is echoing for myself. So this is Peyronie's disease because there is a nodule formed in the substance of the penis, which curves the penis like this. Now this guy, he cannot meet with his wife. So this is a big problem for the patient who has Peyronie's disease. Now its treatment modern medicine, what they will do, they give steroid injection here in the plaque, in the nodule. But actually, it does not work well. Ultimately, the patient suffers. And at the end, patient will go for surgery. The urologist will open this penis and he will remove this plaque and he will repair. But the problem is that after removing one plaque, the patient may have another one after a few months. So the same thing again. This patient comes to homeopath very often because in allopathy there is no medicine to cure it. And you see the problem. You see the problem. It's a big problem for the guy. Now I'm not going to give you the medicine for this one. I can just show you some repertory rubrics which can help you. Can you see the repertory? Hello?
Yeah,
Yes,
yes,
sir.
sir.
Yes, sir.
Okay. So we go to main. You see nodules in the penis. This is one rubric you can take. Nodules in the penis. But I don't say you give medicine, what is written here? No, this only gives you some idea. Yeah, what may be the medicine or how can you find it? Actually, you will have to take the whole history from the patient and according to his symptom totality, you will select the medicine and this will cure him. I have I have a good number of patients and they are very, very happy. They say, we, because you see the suffering, he cannot even share with his friend, with his relative, that his penis became carved. So this is a good case coming to the homeopath, and we can help. We can help. There is another rubric. It can help you in duration. In duration penis. This can also help you. But as I said, you will have to take the whole history, his sexual history, if he has any venereal disease, if history of that, and by the totality you select the medicine. Let us come to our topic again. So after Peyronie's disease, let us come to the new topic which I was going to discuss. This is obstetrics and gynecology. Now, before going to obstetrics, let us discuss some gross anatomy of female genital system. So you can see this is a uterus. Uterus has three parts. This is called fundus of the uterus. Fundus. This dome-shaped part is fundus. This is the body of the uterus, and this is the cervix. So cervix, body, and fundus make the whole uterus. Now this uterus is connected with a tube. You see, it is called fallopian tube or ovum-bearing tube, and this is the ovary. Every month there is one ovum. It comes out by ovulation and taken up by this end of the fallopian tube and comes here. If there is any copulation with a man, his sperm will come and both will meet here. This is called ampulla of the fallopian tube. And after they meet they form zygote, a structure which is called zygote. This zygote takes 1 week time to come to the uterus, and this will be implanted and make the pregnancy. So this is one thing. Now I will show you very briefly the normal process of delivery. Because why you see? Because our subject is here, this is called obstetrics and gynecology. Gynecology means the diseases of the female genital system. It deals with the diseases of female genital system. And obstetrics deals with the pregnancy, labor, puerperium, and the newborn. So let us talk little bit about pregnancy and normal delivery. Pregnancy, after implantation of the zygote in the uterus, it will develop within the uterus for 10 lunar months or 9 calendar months plus 7 days. And then there will be delivery pain, and the uterus will press and compel the baby to outside. And there will be one obstetrician or a midwife who will just assist the process of delivery. He is not here to do so many things. He will follow the process and give due assistance only. So like this, you see, the head is coming out, and the obstetrician or the midwife, she is just helping to make it come out. Now, sometimes this part does not come so easily, and you find the baby is in a problem. The baby has a fetal distress, or maybe the mother has maternal distress. Then we do assisted delivery. We help the delivery. How? We give, this is called forceps. This is obstetric forceps. We apply obstetric forceps inside the vagina and catch hold of the vaginal part, means the head, and take it out. And once the head comes out, the other parts of the body very easily also comes out with the head. Sometimes we don't apply forceps. We apply, this is called ventouse. Ventouse. This is called ventouse delivery. This is ventouse means it creates a negative pressure by a pump outside. This negative pressure will be carried to this cup, and when we will apply this cup to the head of the child, this will catch hold of the cup very tightly, and you can just pull out the head of the baby with this one outside, and then you deflect the pump, and you get the baby on your head. So this is assisted delivery, and this is normal delivery, and this is cesarean section. You see, the obstetrician has incised or cut the uterine wall, and through this cut surface is taking the baby out. Then he will repair this uterus. Okay? Do you hear me?
Yes, sir.
Yes, sir.
But I am having some disturbance. There is echoing in my set. I can leave my set, mobile set. Let me see. Hello. Okay. Now, nice. So these are the topics we will discuss today. In that is echo. So these are the topics we will discuss today. This is called MBBS Hello.
দেখতে নাম তাজা খাওয়াই দেন না, আবার মাইরা লেন না মারে।
একটু করে তো আমাকে ধরো তো, একটু করে একটু রাখো। হ্যালো, আপনারা কি আমার হ্যালো, ডু ইউ হিয়ার মি? হ্যালো।
Yes, sir.
Okay. Good here. So let us first discuss BBF and RBF. What is BBF? It is called vesico-vaginal fistula. RBF means recto-vaginal fistula. So what I wrote here, you see, we have no homeopathy. If a patient comes with BBF and RBF, this is a purely surgical case. But how BBF and RBF occurs, we must know. You see, when there is a delivery process, and if the delivery is delayed delivery, you know, a normal delivery should occur within few hours. But if there is delay of 1 day, 1.5 day, 2 days, something like that, then what will happen? This head, this presently part, when it is coming down, it is stuck here. It is not coming down anymore. So this will go on pressing and pressing. This is the uterine wall. You see, this is the uterus, this is the vagina, this wall, and this is the urinary bladder. This is urinary bladder. So this will go on pressing and pressing. And when it presses, there will be no blood circulation. And if it is prolonged for 1 day, 24 hours, what will happen? This part will degenerate. Now, ultimately, maybe the baby will be delivered, ultimately, say for example, but the lady will find after 1 week or 2 weeks that she cannot catch hold of urine anymore. Urine is flowing involuntarily. What happened? You see, this is the thing what happened. This, by the continuous pressure, the vaginal wall and the bladder wall become degenerated. And afterwards, after 1 week or 2 weeks, this will be sloughed out. This will be sloughed out. And it will make a communication between this the bladder and this is the vagina. So between bladder and vagina, there will be a fistula. This is called fistula. So this is called vesico-vaginal fistula. Now the lady will no longer pass urine through her urinary bladder or urethra. Why? Because there is a sphincter, you know, but there is no sphincter. This is direct communication with the vagina. So she will pass the urine through vagina, and vagina has no sphincter here. So there will be dribbling of urine throughout the day. So this is called true incontinence. So this case, it needs repair either by a good gynecologist or by a good urologist. You cannot do anything here by homeopathic medicine or any medicine, Ayurvedic or, because this is not a medical case. Now, how to know there is BBF or no? So that's why we should learn this subject from the gynecology, and this is written, this is included in our DHMS course event, and of course with BHM. Now, if a lady comes to you, she says that she has delivered a baby before, say, 1.5 months, okay, and after delivery, she started passing urine involuntarily, and she cannot hold the urine anymore. Now, this may be one of the two cases. This is either true incontinence, another is false incontinence. False incontinence means there is no fistula, but the sphincter is loose. This sphincter, this urethral sphincter is loose. So when the patient makes coughing or sneezing, then urine passes. Or if your patient has too much urine collected in the bladder, she cannot hold it anymore. So she will pass the urine involuntarily. So this is called incontinence, but false incontinence. But when there is a fistula, like here, this is called true incontinence. Now, if a patient has false incontinence, we homeopath, we can treat and we can cure. But for a true incontinence, we cannot. So you'll have to diagnose the case. Now, say, I can diagnose, but if you cannot diagnose, no problem. Just you refer the case to a gynecologist. And she will examine by passing a cannula here, and with instruments she can diagnose that this is fistula, vesico-vaginal fistula. When it is vesico-vaginal fistula, you leave the case. This is not your case. Or you refer to the gynecologist or urologist. But if the gynecologist says this is not vesico-vaginal fistula, this is false incontinence, this is called stress incontinence, then you can treat. You can treat it better than the allopathic doctor. So this is one thing. Let us see another case. RBF also like this. If there is a communication between, you see here, sometimes the communication becomes, this is the rectum. This rectum and this is the vagina. If there is fistula between rectum and vagina, this is called RBF, recto-vaginal fistula. Then what will happen? This is more serious than the other case. Her stool will come through the vagina. You see what is the pathetic situation? This lady will have stool through her vagina, and her life will be a messy life. So if you can diagnose, this patient says, I pass my stool through vagina. With experience, he knows this is RBF, recto-vaginal fistula. And if you can not diagnose, you send it to a gynecologist or a surgeon, he can easily diagnose it. Recto-vaginal fistula. If it is recto-vaginal fistula, then again, this case does not belong to us. This is a surgical case. Okay? Now, we go to ectopic pregnancy. You see, this is called ectopic pregnancy. So we must know what is ectopic pregnancy. If you don't know it, sure, we make blunder in many cases. So let us first learn it little bit, because in this little space of time, I cannot describe all the diseases, just I can give some hints. See, this is the ectopic pregnancy. And I showed you before, I told you that zygote occurs here. The female ovum and male sperm meet here. This is called ampulla of fallopian tube. And from here it comes to the uterus and implants here, and there is growth of baby here. But sometimes it happens, the zygote stuck here. He cannot come here. He started implanting here. So there will be pregnancy outside uterus and inside the fallopian tube. This is called ectopic pregnancy. Means pregnancy in a place outside its normal place. This is called ectopic pregnancy. Now you can imagine, because you see the space of the uterus is so big, so to accommodate the baby. But this small fallopian tube, of course, it cannot accommodate a baby of more than 3 months. So when the fetus will grow and grow, ultimately this will rupture the fallopian tube, and there will be huge internal bleeding. And unless the patient is very soon transferred to a good hospital and with blood transfusion, she or she will die. She will die of internal hemorrhagic shock. So this is dangerous. If you find this is a case of ectopic, this is not the case of homeopath. This is not our case. We will send it to a gynecologist as soon as possible. You see, this is the baby. You see, this is the set of the pregnancy inside the fallopian tube. And you see the fallopian tube, it is not very big. So after 2 or 3 months only, this will rupture. And there will be catastrophic bleeding and the patient will die. Now, how can you diagnose this is a case of ectopic pregnancy? So I give you little hints. If a patient is pregnant with ectopic pregnancy, she will give you the complaint, the doctor, I have a short period of amenorrhea. Say, I have 2 months, no mens. She will never say, since last 6 months, I don't have mens. Because this fallopian tube cannot accommodate a pregnancy of 6 months. So this will be small time. You will say 1.5 months or 2 months, amenorrhea means no mens. Then she will say, I have little pain, not much, little pain on my iliac region. I hope you understand what is iliac region. On the side of the lower abdomen, iliac region. I have little pain in the iliac region. And little bleeding occasionally occurs through vagina. Little only, not much. These three signs and symptoms. The short period of amenorrhea, a pain in the one of the iliac region, and little bit bleeding through vagina. Immediately you should suspect the case is ectopic. Then what you will do? You will send the patient to sonologist for ultrasonography. And ultrasonography will diagnose this one. As soon as you find the diagnosis, this is an ectopic pregnancy, you have nothing to do with homeopath. It is not our case. Immediately, you send the case to gynecologist. Immediately, without delay. So also you see, this is not our case. Now we come to another one. This is called gross CPD and obstructed labor. Also, here we suggest this is surgery because otherwise you lose both the patient and the baby, and you maybe in the low with the handle of therapy and you have to close and say this is the lady has this is called contracted pelvis. Contracted. Congenitally, since birth, she has contracted pelvis. The pelvis is so narrow that a normal head cannot pass through it. Or maybe she has normal pelvis, but the head of the baby is very big. So this will not come through. So this is called CPD, cephalopelvic disproportion. And if such case, if you don't do emergency surgery to relieve the case, ultimately what will happen? This uterus will try to push this baby for this pelvis, but as the pelvis is contracted, there will be no delivery. So ultimately the uterus will be exhausted and this will rupture. Baby of course will die and the mother will die also unless she is sent to a hospital immediately and there is plenty of blood supply for transfusion. So if such case, if we find, though I know most of our homeopathic doctors who don't attend delivery cases, but there was a time in the 19th century, our homeopathic doctors and homeopathic hospitals were equipped with the department of gynecology and obstetrics. And you know, there are many books on the homeopathic approach to the practice of obstetrics. If you find there is a delay in delivery, you will have to first check whether there is cephalopelvic disproportion or not. If there is no cephalopelvic disproportion, then the delivery is delayed because uterus is not pushing enough. Then we have many medicine, good medicine. We can apply the medicine to the mother, and there will be good contraction will start, and there will be delivery. What it may happen, it may happen that, the cervix of the uterus, sometimes it does not dilate. When uterus contracts, cervix should dilate also. But you find there is good contraction, but cervix is not dilated. Also, there will be no delivery, and there will be delay in delivery. This is a prolonged labor. So, if there is no CPD development, this proportion, we have good medicine also to dilate the cervix. There are so many medicines. The Simesibuga, even pulsatilla, polophyllum, gelsemium. Just you will have to give it according to symptom similarity. Even chamomilla, the patient has chamomilla nature. So this can dilate and there will be easy delivery. Or sometimes, as I say, there is less contraction of the uterus. Also, we have many medicines we can give and there will be easy delivery without any allopathic medicine. But the thing is that, the homeopath should know little bit of obstetrics. He should know how to examine a pregnant lady, the process of delivery he should know. Otherwise, it is better not to conduct a case of labor, otherwise you will be in problem. And that's why in DHMS you see we have gynecology and obstetrics, this subject is there. And you are supposed to learn it in the homeopathic college. But thing is there, কাজের গরু বলে আছে কিতাবে আছে বলে নেই মানে you have syllabus of obstetrics and gynecology, but there is no training of obstetrics and gynecology in the college, even in the government homeopathic medical college. If some of our students or teachers are here, they know there is obstetrics and gynecology department. There are good teachers. Once upon a time, I found there are two teachers. Both are FCPS in gynecology and obstetrics. They are teaching there. So this is a good opportunity for the student to learn obstetrics and gynecology. But the fallacy is that this is only theoretical learning. They do not have a labor ward or labor emergency room to conduct a normal labor or assisted labor, post delivery or venture delivery. There is nothing like this. But this is a government college and government hospital with about 100 beds. This is very shameful thing and this is sorrowful thing for us that our graduates who are DHMS, they should have learned obstetrics and gynecology very well. And the government has given good teachers there and good facilities. But due to no labor ward or labor emergency room, there is no arrangement for making delivery. That's why our graduates are not learning this thing. But you see the fallacy. A DHMS doctor, he will have government post in the Upajala health complex or maybe district hospital. And if he is posted there, he will be on duty, in emergency duty, along with other allopathic doctors. They will be having 8 hours duty, they will be having 8 hours duty. Now, during his time, if a delivery case comes, if a difficult delivery case comes, maybe there is hand collapse. The hand of the baby is coming out from the vagina, is such a case. Now, without any training on obstetrics and gynecology, how this doctor, this young DHMS doctor, how he can deal with this patient? And he will make maybe dangerous decision, he will harm the case, or he will harm himself also. Because if he cannot handle the case well, maybe the party will make complaint against him. That's why, in this situation, I will ask our authorities, please make arrangement for our students to learn obstetrics and gynecology in theory as well as in practice. Otherwise, just he will lack this part of training for his life. He will never learn it again. He will have no chance. Now you see another case. This is called central placenta previa. Also, this is not our case. As a homeopath, if we find there is central placenta previa, we will refer the case to a hospital under the care of an obstetrician. Why? You see, this is the placenta. Normally, the placenta remains away from the, this is cervix, this is cervix. Placenta is usually here, not here. But sometimes the placenta grows near the cervix. This is called stage 1, this is stage 2, this is stage 3, this is stage 4. In stage 4, all the placenta grows over the cervix. And you see, this is blocking the cervix. Now the baby is here, you see, this is the placenta below the head of the baby. Now how the baby will be delivered? There is no way. If the baby is to deliver, the placenta will separate first. And this will come out. Then the baby. And by this time there will be huge bleeding. And this bleeding cannot be stopped. So this case needs cesarean section. Cesarean section is a pure indication if there is central placenta previa. Now how can you know it as a homeopath? If a patient comes to me, how I understand this is a case of central placenta previa, this is easy, I am telling you. The patient will say, patient will come and say, Doctor, I have 6 months pregnancy or maybe 7 months pregnancy. And off and on, I have vaginal bleeding, little bit, sometimes more, sometimes less. So this case may be, this is called antepartum hemorrhage. This may be accidental hemorrhage or maybe placenta previa. So nowadays this is very easy. While we were students, but in our younger age, there was no ultrasonography. So you see, we used to clinically diagnose the case. Nowadays, you can just send the case to a sonologist for ultrasonography. So ultrasonography will confirm that this is a case of placenta previa. If you see this is placenta previa, this is not your case. This means this is not a case of our homeopath. You just refer the case to a gynecologist. Now let us see more cases. Placenta previa. So this is if it is central placenta previa, there is no place of doing homeopathy. This is surgical case purely. Now we find there are congenital deformity, deformity of uterus, deformity of internal genital organs since birth. What are the cases? This is called, you see, one is bicornuate uterus. The uterus should be, you see, uterus should be one single cavity, but you may find there is a septum here, there is a wall in between uterus, and this became two-walled uterus, two-roomed uterus, because bicornuate uterus. If there is bicornuate uterus, the lady will complain that I am having abortion every 3-4 months. I cannot accommodate a baby more than say 3, 4 or 5 months. Then it becomes abortion. So if you
তুই কি খাবি খিচুড়ি খাবি মাংস দিমো তাহলে দাদি খাবার দিয়া
Sorry, Rebecca ma'am, please.
So if you find such case, please. So if you find such case, it is very easy. You send the case for ultrasonography. Ultrasonography may diagnose the case as bicornuate uterus. If it is bicornuate uterus, this uterus should be repaired by the gynecologist. He should cut out this septum and make it a single cavity. Then only this lady will have normal delivery. So again, you see, this is not our case. This is called bicornuate uterus. Then there may be imperforate hymen. A lady having hymen imperforate, and say one girl, 16-year girl came to you, brought by her mother, that you see, my daughter has all the secondary sex character. She has good breasts, then the hair, pubic hair and everything, but no mens. So before giving any homeopathic medicine, you must examine the case. You may find this hymen, usually the female's hymen, they have perforation. So this perforation, males come. Sometimes this is tear, rupture. So this proton hymen, males can come. But if it is imperforate, whole vagina is closed by a membrane. This is called imperforate hymen. So there will be no males. So there is no homeopathic treatment. We will have to send it to gynecologist, and he will make very simple a crisscross incision, and the case is over. This you will have good males afterward. So these are actually pure surgical cases. Now let us come to cases where um, uh, we can play. Say benign tumors of ovary, endometriosis cyst, and tumor of uterus. A patient comes to you that she has a benign tumor of say about 6 into 6 centimeter size. It's a benign tumor. The lady is about 35 years. So this is a good case for us to treat it homeopathically. And this ovarian cyst may disappear. But at the same time, I say you, if there is a very big ovarian cyst, very big, it can be like anything. And there is suspicion that it may go into cancerous chain. So it is so big, you cannot cure it very soon, or you may not cure at all. And the patient will have much problem. She will have very big abdomen, she will have urinary complaints, she will have uh, defecation complaint. So it is better if it is so big, you refer it to gynecologist to remove this ovarian cyst, so big. But if it is moderate size, small or moderate size, this is our case, you can treat. Same uterus. If in the uterus there are fibroids, small to moderate size, yes, we can treat. We can treat and we can cure. But if there is adenomyosis, this is called adenomyosis, whole uterus is having tumorous swelling, whole uterus. And patient has much bleeding, metrorrhagia, and she is having anemia, and she will have to take blood transfusion for that. In such case, you can try for some time only. But you find if you cannot control the bleeding, neither you are controlling the size of the uterus, it is better to send it to gynecologist. If it is very big and bleeding is so much. But other case, yes, you can treat. Now let us come to another case. This is called endometriotic cyst. It is also common. It comes to us. What you will do? Let us see what is endometriosis first. And this is, you see, this is uterus, this is ovarian tumor. This is a big ovarian tumor. And this is not only tumor, cancerous tumor, ovarian carcinoma, this one. It is better to leave this case. It is better not to accept this case. Because if it is a big tumor and there is cancerous chain, it is very difficult. It is very difficult to cure or control this case. But if it is a moderate size of ovarian tumor like this one, it is very easy to treat. Again, you see these are fibroid tumor. This is fibroid. Fibroid tumor are of three types. Which one is just near the outer surface? This is called subserous fibroid. Which is inside the muscular layer. This is called intramural fibroid. And which one is just near the cavity of the uterus? This is called endometrial submucous fibroid or endometrial polyp. If it is subserous, there will be no bleeding. If it is endometrial, there will be huge bleeding, metrorrhagia, menorrhagia. So again, if it is a smaller one or moderate size one, okay, you treat it. But if it is very big, distorting the whole uterus, and it is pressing the urinary bladder and the lady having frequency of micturition, she cannot control the urination in such cases. And if there is suspicion that there are cancerous changes, it is better not to accept this case. It is better you first go to gynecologist and get it examined and see what is their opinion. Then only you can think whether you will take or not. Now what I want to show you, endometriosis. You see, this is called endometriosis. Endometriosis. What is it? You know, the ovary has an epithelial cells. These epithelial cells should be only in the ovary, should be. But our nature has some anomaly sometimes. There will be ovarian cells in other place of the uterus, maybe in the abdomen, maybe in the nose. So when there will be menstruation, there will be menstruation in the uterus as well as menstruation outside the uterus, as well as menstruation from the nose. It's called vicarious menstruation. So you see, during menstruation there should be bleeding from the inside of the uterus. But because this epithelium, this uterine epithelium, this is outside here. So when there will be menstruation, there will be blood here. Also, some blood will be discharging from here. Now what will happen? This blood cannot come out because there is no way to come out. So this blood will be absorbed little bit, and this will be very thickened blood, and this will make adhesion of all the fallopian tube here. And the fallopian tube can no longer take the ovum for fertilization, for pregnancy. So this lady will be of primary infertility or secondary infertility. This will say, I cannot conceive a baby. What is the problem? The doctor did examination, he said, I have endometriosis. Endometriosis means is endometrial epithelium, which should be only in the uterus. This is endometrial epithelium, which should be only in the uterus. Here it is also present in the ovary. It is also present in other parts of the body. So when there is menstruation, there will be menstruation here, also menstruation here. This blood will come out normally through the vagina, but this blood cannot come. Rather, this will be thickened, and this will make adhesion all over here in the pelvis. So what is the treatment in conventional medicine? What they do, you see, they do it like this is called laparoscopy. They'll make a laparoscopy. They will send 3 or 4 tube like this, metallic tube, and they will do operation. They will remove the endometric cyst, this collection of blood making a cyst. They will remove the endometric cyst, and also they will remove the adhesion of the fallopian tube. There are adhesion of the fallopian tube. That's why there is no pregnancy, because the endometrium tube cannot catch the ovum. So they will remove this adhesion from here. But what will happen, because they cannot remove the whole tissue. So from next month again there will be collection of blood. And again there will be adhesion. And the lady will have same thing again with the 6 months. So mostly this is a failed treatment in the conventional medicine. But this can is that we homeopath, we can help the patient like anything. And I am sure many of our homeopaths here, they have treated this endometriosis and they cured it. There are here no special medicine. Just take the history of the patient, take the menstrual history, take the local history, how is the pain, then take the general symptoms, other symptoms, mental symptoms, and you will find, say, some medicine will come, say, there is leaky cyst, You may find that apis comes. You may find lycopodium comes. You may find some bowel nosode, psychococcus comes. You may find sepia comes. Leccan comes. And you give the medicine and you find this is her complaint is improving and improving. And if you do the ultrasonography or vaginal sonography, you find that the cyst is already disappeared. The cyst has disappeared. And maybe the patient was infertile, now she will be pregnant. So this case, endometric cyst of the ovary, yes, we homeopath, we can treat and we can bring success to our practice and to the patient herself also. Now let us see what remains. And benign of the breast. There are benign tumors of the breast. You know, there are tumors in the breast. There is fibroadenoma. There is fibrocystic tumor. Most of these cases are benign, and we can treat by homeopathic medicine. In many cases, you can treat and you can cure. But if you find there is cancer by FNAC or by core biopsy, if they say there is cancer in the breast tumor, then you take care. Whether you will proceed or you will not. But if it is a benign one, yes, you can take the history, you take the symptom, make an amnesis, select the medicine, and you can treat and you can cure the case. Let us come to our last topic today, cancer. But I think we cannot finish this one today. So let us start and we will keep the rest for the next week. So this is homeopathic approach to neoplasm. Let us know what is neoplasm. And let me enumerate the definition. This is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissue and persists in the same excessive manner after the cessation of stimuli which evoke the change. This part. You know, our cell, body tissue cell, they can proliferate. There is mitosis, there is meiosis, there is hyperplasia, there is hypertrophy. But for that hyperplasia, it needs a stimulation. This may be a chemical stimulation, this may be a viral stimulation, this may be some immunological stimulation. By this stimulation, there will be growth of cells, and you will find that there is a tumor, there is a mass. But normally, if the stimulation is removed, this will not further grow. The growth will be stopped. But neoplasm is that even if the stimulation is removed, this will go on proliferating and making the mass bigger and bigger. So this is neoplasm. Even when the cessation of stimuli, you remove the stimuli, you remove the inducing agent, but still there will be hyperplasia of the cells and the tumor size will be bigger and bigger. This is abnormal proliferation of cells. You can say neoplasm is abnormal and excessive proliferation of cells. Now this may be benign, this may be malignant. Benign means no cancer. So benign has some character and malignant neoplasm has some character. Let us see what is the character. Benign neoplasm composed of cells which are well differentiated. It means what? One cell is like another cell. These are differentiated. If it is a epithelial cell, all are like a epithelial cell. All have similar type of chromosome and similar type of cytoplasm. Remain localized without tendency to invade the surrounding structure. And this proliferation of cell will remain within the tissue, within the organ. Say if it is hyperplasia of prostate, say if the prostate gland is going to neoplastic change. So if it is benign, there will be hyperplasia limited within the prostate. It will never cross prostate and invade the surrounding structure and are amenable to complete surgical removal. And if you remove this whole structure, it means this neoplastic change will be over. But in case of malignancy, this is just completely different. This will be composed of cells which are undifferentiated. We'll find the cells, one is not like another one. One is round, one other is rhomboid, something like this. One is big, one is small, one has a chromosome more, one has less, one has cytoplasm less, one has cytoplasm more, like this. This will be undifferentiated and of dissimilar size. And they have tendency to invade adjacent structure. And this tumor will invade the adjacent structure. If there is neoplastic change in cervix, this is malignant neoplasia. This will invade the surrounding structure, means it will invade the urinary bladder, it will invade the rectum. So this has tendency to invade adjacent structure and spread distally. And you see, say there is a tumor in the cervix, but it can spread distally. It has gone to the brain, it has gone to the bone, it has gone to liver. So this has tendency to distal spread. But the benign will never do distal spread. And tendency to recurrence after surgical removal. And even if you remove the tumorous mass, there will be more chances of recurrence. So these are the two types of neoplasia. Benign neoplasia is okay, better, it is safe, but malignant neoplasia is unsafe. I will finish the lecture today by describing this difference, and inshallah I hope next day we'll go further. Now there is a good difference here, you see. I give the differentiation. What is the difference between benign and malignant tumors? Benign tumors are slow growing. The tumor will grow very slowly. But the malignant one, it will grow very rapidly. And benign will not metastasize. Metastasize is part. Spread to the other organ. Benign will never spread to other organ. But in case of malignancy, cancerous metastasis will occur. Means this will spread to near and as well as distal organ. Benign are non-invasive, as I say. If there is prostatic neoplasia, this will never go beyond prostate. This will never invade the adjacent structure. But in malignancy, this will always invade the adjacent structures or organs. The tumor cells will be well differentiated. As I said, all the cells will be of similar structure. But in cancer, cells will be of different structure. Capsule always present. In benign, the capsule of the organ will remain intact. If it is prostate, prostate has a capsule. Kidney has a capsule. So if there is benign tumor, this capsule will never rupture. This capsule will remain intact. But in case of cancer, capsule will be destroyed. Capsule will rupture and there will be spread to outside organs. Nuclear, you come here. Nuclear cytoplasm ratio 1:4. It means in benign tumor, you see the nucleus will be 1 and cytoplasm will be its 4 times. The nucleus is like this, cytoplasm like this. But in case of cancer, this will be almost same. It means its nucleus will be very big in case of cancer. Benign usually not fatal. Benign usually not fatal means not dangerous. It will not kill the patient. But malignancy, this will be fatal. It will kill the patient. In benign tumor, usually not occur after surgery. Usually, if you say prostate, one patient has a benign enlargement of the prostate. The doctor removes the prostate. Usually, it does not recur. Usually. But if it is Malignancy, of course, it will recur. One more thing, this page that finish also, because this is easy. Mode of spread of cancer. How cancer spreads from one place to another place. You see, there are two ways. First one is local spread or direct invasion. So if there is a cancer in the gallbladder, it will go to the liver, of course. If there is a cancer in the stomach, it will say go to the pancreas. This is called local spread. If there is cancer in the cervix, it will invade the urinary bladder, or it will invade the rectum. This is called local spread or direct invasion. Another is distant spread. The cancer is in the testes, but there is another cancer in the brain. How? So this is called distant spread. From testes through blood, it has gone to the brain. So distant spread can occur by three ways. One is lymphatic spread. You know there is lymphatic channel. Like blood channel, we have lymphatic channel also. By lymphatic channel, it can spread. And of course, hematogenous spread by blood vessel. By blood vessel, a tumor of the prostate will come to the say liver. Then it will go to the bone. So through blood channels, it can spread. And seedling within the body cavity. Seedling means if a cancer of liver, this will make small seedling, small cell. This will flow in the abdominal fluid, and this will settle on the ovary. So from the cancer in the liver, there will be cancer in the ovary. This is called seedling within the body cavity. And again, grading of cancer. Sometimes you will find the report comes from the allopathic doctor or from the pathologist, and he said the cancer is grade 4. What does it mean? So you see, if whole tumor contains only 25% malignant cell, 75% normal cell, this is called grade 1. It means here the cancerous force has less initiative. You can still control. But grade 2, if the malignant cell increases from 25 to 50%. Grade 3 from 50 to 75%. And grade 4 more than 75%. So if it is a case of grade 4 cancer, if you find the patient came for breast cancer, the report came this is grade 4 cancer. The report came of stomach, grade 4 cancer. Of pancreas, grade 4. Grade 4 means almost all the organs became cancer. And it is very difficult to cure it. In that case, in conventional medicine, they will never cure that case. They will only say there will be palliative treatment. Also in homeopathy, we will discuss next day. In such case, we cannot venture, we cannot boast that yes, we can cure. No. This is only palliative care we can give. In homeopathy also there are good palliative care for cancer patients. And we can give that palliative care to the cancer patient. But this you will have to decide with the patient's party by counseling, by discussion. You will have to talk with the patient party that this is the case of grade 4 cancer. Almost all the, if it is pancreas, almost all the pancreas became cancerous. And it will never be cured. Even you cannot cure it through chemotherapy or radiotherapy by any means. So even in conventional medicine, they will give only palliative therapy. So if you want homeopathic medicine, I can give, but only palliative therapy. It will never be cured. Or even you said that I cannot cure it. In such case, I can give only palliative treatment. If the patient agrees, okay. If not agree, why? You don't take this case. So next day, inshallah, we'll go for etiology of cancer, then evolution of chronic disease and cancer, and how to diagnose a case of cancer, then importance of diagnosis of cancer, then various cancer of various organs. All the organs from head to foot we'll discuss, and we'll try to pinpoint what we can do as a treatment. I hope, and also I will show you this thing, the cancer, and also one thing I have added here in Bengali lecture. I did not put it here. I will discuss little bit about. You see this man. Just see there. I'll discuss about these people who have who are called homeopathic oncologists. They are very famous and they have much experience to treat cancer cases by homeopathic treatment. I will try to just give a brief discussion about that. So today, thank you very much. Till you are here, even after so much problem in our deliberation, in our presentation, and of course we'll have to agree because we don't have any hand on our internet problem, on our electricity. So just this is our life. I hope next day there will be good internet line and we can finish the lecture very well. So thank you very much again. And now I shift to Dr. Anwar. If you have any question, I think still we have 15 minutes. We can take your question and we will try to give you answer as much as we can. Okay, Assalamu alaikum wa rahmatullah, Dr. Anwar. Now you have the microphone. Thank you.
Thank you very much, sir, for your wonderful and valuable discussion. I hope today's discussion is very useful for every patient, present every homeopath in his their
If there is any
practice.
question, just ask them. They can ask related to our topics today, and I will try to give them answer.
If anyone has any question, you can ask your question. Please raise your hand. Hello. If anyone has any question, you can ask your question.
Nurmia. Nurmia has.
Assalamu alaikum, sir.
Alaikum assalam wa rahmatullah. Follow. Yes, yes.
স্যার প্যাথোলজি রিপোর্ট নিয়ে একটা জানার ছিল স্যার।
No, here only. Okay, okay. You can please here try to put your question in English. But if you are not able, of course, no problem. You can put it in Bengali. We will translate it in English and we will give the answer in English because we want to make a level of our standard of our lecture here. This is English lecture, We give Bengali lecture in other weeks. That's for the same topic. But here at least let us try to deliver the lecture in English as well as from the audience you try to ask questions also in English. Because if you leave Bangladesh and if you go to even India outside West Bengal to attend a homeopathic seminar, you will have to listen all the lectures in English. And if you have anything in your mind to ask, you will have to ask that question in English. And you will have to listen also his answer in English. That's why let us practice it here. Because in Bangladesh, nobody is doing this effort. We started this effort only to elevate the level of our viewers so that they can practice English as a listener and as a presenter. Thank you. Okay, you can tell in Bengali, no problem.
Bilateral renal cyst with right side by huge pleural effusion.
So what do you want? Renal cyst.
Yes, sir.
Renal cyst has nothing to do with pleural effusion. Pleural effusion is something else. Renal cyst is something else. I don't understand what you want to say. Renal cyst means a cyst in the kidney. This is in the abdomen. And pleural effusion means collection of water in chest, in the pleural cavity. So how can you say renal? So it may happen that the patient has both the things, pleural effusion as well as a cyst in the kidney. This may be.
Yes, sir. Yes, sir.
But what is your
Okay.
question then? What's your question? What do you want to ask me? Anyway, okay. Thank you for your question. Thank you. Anybody else?
Yes, sir. Okay.
Okay. Anybody else? Be bold to ask any question and try to ask question in English. Try to take the answer in English and try to speak in English. If you have